So our last presentation is the first decade of laparoscopic pancreaticoduodenectomy in the United States, costs and outcomes using the nationwide inpatient sample, presented by Dr. Tran from Stanford University.
Thank you for the opportunity to present our research on the first decade laparoscopic pancreaticoduodenectomy using a nationwide inpatient sample. We have no disclosures. Laparoscopic pancreaticoduodenectomy is an extremely complex operation that requires considerable expertise. Our understanding of this procedure has been limited to a single institution case series. The question remains, is laparoscopic Whipple justified? Proponents of this procedure argue that it is associated with shorter length of stay, improved morbidity, and decreased blood loss. However, critics of this procedure argue that it is an extremely complex operation that is often associated with longer operative time. The oncologic equivalence remains unproven, and it is associated with quite a high surgical cost. So we sought to answer the question, what is the US experience of laparoscopic Whipple? We used a nationwide inpatient sample to assess morbidity, mortality, and total hospital charges in patients who underwent laparoscopic Whipple from 2000 to 2010. High-volume hospitals were defined as those hospitals that perform more than 20 pancreatic resections of any kind. This was previously defined in literature on volume outcomes relationship. We identified 1,186 hospitals. More than nearly 16,000 Whipples were performed during the last decade. Of those, 681 cases were performed laparoscopically. This consists of 4.4% of the entire cohort. We first evaluated outcomes between open and laparoscopic cases. In this table, you can see that patients underwent laparoscopic Whipple tended to be slightly older. The comorbidities were fairly similar, with the exception of diabetes. Not surprisingly, laparoscopic Whipples were more commonly performed in high-volume hospitals, particularly hospitals that perform a high volume of any kind of pancreatic resection. As far as postoperative outcomes, laparoscopic Whipples were associated with lower morbidity, lower rates of pulmonary complications, decreased need for blood transfusion, shorter length of stay by 1 day. Mortality and hospital charges were similar. We next evaluated outcomes based on hospital volume. This table shows a preoperative characteristic of patients undergoing laparoscopic Whipples stratified by hospital volume. Again, high volume hospitals were those that perform a high number of pancreatic resections. If you look at postoperative outcomes in patients undergoing laparoscopic pancreaticoduodenectomy, these patients who had Whipples performed high volume hospitals were associated with lower morbidity, decreased pulmonary complications, decreased length of stay. Mortality rates were slightly lower in the high volume group, and the hospital charges were $30,000 lower in the high volume group. This figure illustrates the distribution of laparoscopic cases performed in the last 10 years as stratified by hospital volume. As you can see, purple represents high volume and green represents low volume. Laparoscopic Whipples performed in high volume institutions tended to be skewed towards the left. They cost much less compared to hospitals Whipples performed in low volume hospitals. These cases tend to have a wider variation in charges. So this bar graph shows only hospitals that perform any laparoscopic Whipples in the last 10 years. As you can see, laparoscopic Whipples, which is represented in red, really represents a very tiny fraction of any Whipples performed in these hospitals. Blue represents open Whipples. High volume hospitals are portrayed on your right. And you can see there's quite a bit of variation in number of laparoscopic Whipples, even in those high volume hospitals. So this raises the question, does one have to do a high number of laparoscopic Whipples to have a good outcome? In looking at the NIST database, we identify essentially 15 hospitals that perform more than 50 Whipples in the last 10 years. This is represented in the middle bar. These hospitals had a morbidity of 33%. Hospitals that perform lap Whipples, fewer than 50 lap Whipples in the last 10 years, their morbidity was actually about 44%. That being said, laparoscopic Whipples perform in hospitals that have a high number of pancreatic cases annually. This is shown on the right-hand side. The morbidity appears relatively similar to those 15 hospitals that perform more than 50 Whipples in the last 10 years. In a multivariate analysis, we determined that operative approach, lap versus open, was not a significant predictor of mortality. When we look at complications in the laparoscopic cohort, age and comorbidity was not significant. However, hospital volume, those that perform a high number of pancreatic cases, hospital volume was associated with improved outcomes, a 30% risk reduction of complications. So in conclusion, despite early in the learning curve, laparoscopic Whipple is associated with better outcomes than expected in the first decade in the US. There's lower morbidity and shorter length of stay. Hospitals that perform a higher volume of pancreatic operations achieve better outcomes at a lower overall cost than hospitals that perform few pancreatic operations. Laparoscopic Whipples performed in hospitals that perform a high volume of pancreatic surgery appears to be safe. Thank you.
Thank you very much. I think that the issue of high volume versus low volume centers for pancreaticoduodenectomy has been, pretty well studied and pretty well answered. So we appreciate the fact that you're looking at a big database and you're looking at outcomes, costs, complication rates for open versus lap. But obviously there's no selection between patients who are undergoing lap versus open. And so are we really comparing apples to apples? And would it be better to have sort of a case-matched series so that you can truly compare cost and outcomes?
Thank you very much for the question. I do agree that there is a significant component of patient selection that NIST does not have available in its database. Important variables such as tumor size, whether or not the pancreas is soft or hard, these are important variables that we don't have in our database.
Thank you.
For the presentation, and according to your abstract on the APP, CG's APP, I learned that you state that the high volume hospital are associated with the lower risk of mortality. And you know that the different tumors have different biological characteristics. So I wonder whether the etiology of the tumors of the two groups, the low-level hospital and high-level hospital, are similar in your study.
So we do not have outcomes beyond 30 days, so we cannot determine the oncologic efficacy between high versus low volume hospitals.
Okay, thank you.
Last question, Dr. Aspin.
Yes, nice presentation. Thank you for looking into this. A couple of comments. The selection varies according to the experience. Because, for example, once you have done the learning curve, currently I think the easiest Whipples that we have are being done open, except for the main portal vein resections. Because we found out that the laparoscopic approach is better for the obese people, and some of the bigger cases you can see with magnification. My question to you is, what do you propose to assess if there should be credentialing and regionalization of these cases, and how we would do that? And that's a question for Dr. Iannitti too.
Right.
That's a loaded question.
Well, first of all, it's an honor to have you, to have any question asked by you. I read all your papers on this procedure, so thank you very much. So as far as proposing credentialing, I think one of the parameters we can use to determine whether or not one has achieved competency in this procedure is operative time. Naturally, early during the learning curve, it takes much longer to perform such a complex procedure, but as you do 10, 20, 30, 40, I imagine the operative time would be much lower. So although we don't have a cutoff, how long of a laparoscopic operation would, if you perform an operation less than, say, 4 hours, that's indicative that you're very skilled at performing laparoscopic Whipples versus those who perform 8 to 10 hours. I don't have a cutoff for that, but then that's where a multi-institutional study would be very useful. This has been studied, I believe, by the Emory group in the past. They had published papers using on distal pancreatectomy, looking at operative time, oncologic equivalence. So I think there's a need to do multi-institutional studies for laparoscopic Whipples.
And regarding a question regarding regionalization, I'll just say at the end of the day, the economics of healthcare is going to drive that. I want to congratulate all the authors for their fantastic work in presenting. Thank you very much. And I think our session is done. Thank you very much.
Thank you.